it's a great honor to be a part of Cervical Cancer MUKT Bharat under Madam Dr. Sharda Jain, Dr. Sadhna, Dr. Ragini. They are always an inspiration and a great guidance to work more and more for the cause of women. So today I will talk and share that we all gynecologists should know that we can do secondary prevention with cervical cancer screening. So if we go through that, the cervical cancer is the fourth most common cancer worldwide and is the second commonest in the low medium income groups, especially India also. And if we go through the figures of 2018, 3,11,000 and more worldwide annual deaths happen due to cervical cancer. And in India, it is tragic to see that more than 77,000 deaths they occur annually because of cervical cancer, which is 3 times the maternal death. The whole country, the whole world is working on the maternal deaths, and we have done how to stop the direct causes of death. So this is the site where we are really lacking, and we are perhaps ignorant about it, that 3 times maternal deaths is because of cervical cancer in India, and the median age affected is 38 years. We all know that WHO has already given us a call for elimination of cervical cancer by 2030. That means that no country in the world should have more than 4 cases per 100,000 women years. And we have to achieve the vaccination of young girls up to the age of 15 years, up to the range of 90%. And it is very sad that we have not even covered 0.5% of the girls yet. And so much is to be covered till 2030. For primary prevention, it is vaccination, vaccination, and only vaccination. So we need to pace our efforts. And for screening, for secondary prevention, 70% of the women between the age of 35 to 45 years must be screened for cervical cancer. And 90% of the women should have, if they have cervical cancer, it should be an early diagnosis and appropriate management in time as a tertiary prevention. So 2030 SDG goal, it targets to reduce the mortality due to cervical cancer to the extent of 30%. That is our aim. And we all countries, and especially India, needs really to work hard to achieve it. So we have talked today, we will talk on secondary prevention. That is how we can screen for cervical cancer and diagnose precancerous lesion and treat them well in time. So effective primary and secondary prevention, we all know, shall prevent most of the cervical cancer. And if it is diagnosed that patient has cervical cancer, then early stage and appropriate management are the mainstay. So as concerns the risk factor, older age, low socioeconomic status, lower education level, low empowerment, multiple sexual partners, multiparity, early age, not only at the first coitus, but also early age at the first pregnancy, cigarette smoking, they are known risk factors. Long-term use of oral contraceptive use may also be a risk factor. Then a diet which is low in folate, carotene, and vitamin C may predispose to cervical cancer. Then history of sexually transmitted infections, HPV infection, and herpes simplex virus infection, and HIV infections, they predispose to cervical cancer. And infection with the specific types of HPV, especially 16 and 18, where 99.7% of cervical cancer are because of those. So they are highest risk factors. Then a woman who is already on immunosuppression for some reason is also a risk factor for cervical cancer. So in 99.7%, HPV or human papilloma virus is the necessary cause of cervical cancer. That is why the vaccination in girls is highly preventive of cervical cancer. The HPV 16 and 18, they cause more than 75% of cervical cancers and more than 50% of vulval and vaginal cancers, while more than 90% of anogenital warts are because of HPV 6 and 11. Now, we all know that earlier we always used to talk CIN1, CIN2, CIN3, and which has been, there's not much difference. This was as per NICE guidelines, and now we are following BHARAT, which I will just now come on, that CIN1 is nothing but LSIN, low-grade squamous intraepithelial lesion, while CIN2 and CIN3, they correspond to high-grade HSIN. So we all must be very, 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 very clear that CIN1 and LSIL, they are not precursor to cervical cancer. It is only that in 80%, they regress within 6 years. So we should follow up a case of LSIL or CIN1, but not that it is a direct indication for hysterectomy. So this is a message for all those working in the field at primary level or secondary levels. So every woman, or more than 80% of women, they have human papilloma virus infection during their journey of life once upon a time. However, 80% of it clears of its own, and the lesion, it regresses by itself in due course. But 20% of those infected with human papilloma virus, they may develop a low-grade squamous intraepithelial neoplasia, and of this LSIL, 80% again will clear in due course of time, maybe in 6 months, 1 year, or up to 6 years. While 20% of women with LSIL will go into high-grade squamous intraepithelial lesions and may develop invasive cancer. So the HPV transmission can be through the sexual route, fomites, by close personal contact, or by a minor trauma at the site of inoculation. Then who are the women at risk? We should know that every woman is at risk of cervical cancer. And up to 70% of women, they acquire HPV infection in their lifetime. So we have just now talked that most of them, the infection, it resolves, while in 5 to 10%, it may develop into persistent infection and may lead to cervical cancer. Now, we should know that the age group for HPV infection leading to anogenital warts is 20 to 24 years. This is the highest peak period when a woman is most exposed to anogenital warts due to HPV infection, because this is the period of highest sexual activity. Then from the age of 29 years till the age of 46 or 47 years, the women, this is a high risk zone for cervical cancer. Now, so we have to devise a screening method which should be simple, which should be cheap, acceptable to the population, should be accurate, with good sensitivity and specificity, and every paramedic should be able to perform it, and the better would be even if it can be performed by the patient or the woman herself. So, screening for early detection of precancerous will improve the prognosis, will decrease the morbidity and mortality due to cervical cancer. It will increase the survival rates, it will reduce the radical treatment, and will be cost effective, as well as it will be reassuring for the women and the families. Now, cervical cancer, the best part for cervical cancer is this is one cancer which is ideal for screening, and because cervix is easily accessible for examination, and the cervical cancer has a long latent precancerous phase, so we have enough time, and if we find a pre-malignant lesion, to treat that and prevent cervical cancer. And the natural history of cervical cancer is very well known to us. Now, a little word we should know that about the transformation zone. Now, as the woman grows, the transformation zone is the area where the squamous epithelium of cervix, it joins with the columnar epithelium. So, but this is not statory in throughout the life. It doesn't remain at the same level throughout the life. Now, if we can see that this one, the outer one is the original squamocolumnar junction. But with age, this squamocolumnar junction, it goes on moving, and here this is the new squamocolumnar junction. So the area between the original squamocolumnar junction and the new squamocolumnar junction is the transformation zone. This one you can see, all of you, which is the focus on colposcopy, and it is this side, this transformation zone, where we need to look very accurately for any changes. Maybe we are doing a via villi and colposcopy after via villi, and this is the changes we have to notice in the squamocolumnar junction, which is moving throughout the life. Now, the transformation zone, so it is the region of the cervix where the columnar epithelium is being replaced by the metastatic squamous epithelium. And this can be type 1, type 2, and type 3. Type 1 is ectocervical, where the entire transformation zone is visible. And type 2 is endocervical, where the transformation zone is entirely visible and has endocervical component. And type 3 is where the entire transformation zone is not visible. So here we can see this is the type 1. This is type 2 transformation zone, and this is the type 3 where the new transformation transformation zone and squamocolumnar junction is not visible. So here you can see this is diagrammatic picture of type 1. This is type 2 transformation zone, and this is type 3 where the visibility of the new transformation zone is in the endocervix. So for this we have different screening modalities as secondary prevention. Then visual inspection using acetic acid. I think this is the simplest, can be done at a sub-center, primary health center, at a civil hospital, or anyone can do this in OPD also. So then we'll come one by one on each. Then second is visual inspection using Lugol's iodine or Willi. Then pap smear cytology, which we are doing for a long time. And next come colposcopy, and recent and the best modality and the first line as per new guidelines and as per worldwide protocols is human papilloma virus testing. This should be the first line wherever it's available. Then experimental polar probe, laser induced fluorescence, and biomarkers like HPV mRNA transcripts, P16 ink 4A staining, Ki67, and MYC telomerase, MCM2, TOPA 2A. So these are still in the experimental line. Now, every one thing is very varying, that every society has a different guideline. So we are developing countries, so we always follow a WHO guidelines. Now WHO recommends that we have to screen general population as well as women living with HIV. we all should know that all women living with HIV are at a high risk of having cervical cancer. The cervical screening should start at age of 30 years among general population and by age of 25 years among women who are living with HIV. And after the age of 50 years and after the 2 consecutive negative screen results are consistent, then we can stop the cervical screening at the age of 50 years. It applies both to the general population as well as women living with HIV. Now, if we are screening with HPV DNA, then a regular screening interval has to be every 5 to 10 years or 2 screens between 25 to 30 years at interval of 5 to 10 years is justified. And women who are living with HIV start screening at 25 years. The interval with HPV DNA screening should be 3 to 5 years. Where HPV DNA screening is not yet operational, WHO suggests that a regular screening interval of every 3 years using VIA or pap smear cytology should remain as primary screening test among both the general population of women and women living with HIV. Now, when we screen a patient, our goal is to treat the patient. So for this, we can either follow screen and treat approach, screen, triage and treat approach. So screen and treat approach is using HPV DNA. WHO suggests that treating women who test positive for HPV DNA among the general population of the women. Now, what is screen, triage and treat approach? When HPV DNA testing is used, WHO suggests using partial genotype or colposcopy or VIA or cytology to triage women after a positive HPV DNA test and then treat. So these samples, as per WHO, HPV DNA can be taken by a healthcare provider or they can be self-collected samples among both the general population as well as women living with HIV. A regular screening interval of 5 to 10 years should be there with HPV DNA and 3 years with VIA or pap smear screening. Now, if a woman has a primary test screening positive by HPV DNA and then negative on a triage test, she needs to be retested with HPV DNA testing at 24 months. So HPV DNA on the first test positive, she is negative on triage test, retest her after 24 months. Now HPV, if you have screened her with cytology and she tests positive on the primary screen, then but she has a normal colposcopy, she needs a retest with HPV DNA after 12 months. So pap smear screening positive, colposcopy negative on triage, and you need to retest this women with HPV DNA at 12 months. Now, if a woman from general population who has been treated for a confirmed HSIL or CIN2 or 3 or adenocarcinoma in situ or treated as a result of positive screening, she should be retested at 12 months with HPV DNA. So we should know if first test is positive and subsequent tests are negative, retest with HPV DNA at 24 months. If she has been treated for a precancerous cervical lesion, HSIL or CIN2 or 3, retest at 12 months with HPV DNA testing till it is negative. If negative is, if it's maintained when it comes negative, afterwards you can screen at the regular intervals. It's not that we have treated a precancerous lesion and we leave that patient. we always have to follow that patient till 50 years, till 2 consecutive screening tests are negative. Now, so what we have learned is that we can follow screen and treat, that we just screen the patient. So, and we just go for treatment at the same sitting. Maybe we do a colposcopy there and then, a biopsy and an ablative procedure, or do a leap or conization there and then. Or if it is a frank lesion, then we start the cancer treatment. Or the second step can be that we do screen, we do triage, and then we do the treatment. Now, for HPV DNA testing, we have various methods: hybrid capture 2, Cervista HPV-HR, Cervista HPV-1618, and Cobas 4800. The sensitivity and specificity of Cervista HPV-HR is 97.6 and 93%, and of Cobas 4800 is 91% and 97% respectively. The Cobas HPV testing is recommended as an alternative to current cytology-based cancer screening methods in women who are 25 years or older, as per ACOG Practice Bulletin 2016. So, what do we summarize? That primary HPV screening should be done, and if she is positive for type 16 and 18, we can do screen and treat, or screen, triage and treat. So we can go for colposcopy. Now, if on primary screen she is positive for HPV other than 16 and 18, we should go for cytology. And if cytology founds atypical squamous cell ascus, then we should go for colposcopy. 16-18 positive, again go for colposcopy. Now, if she's had been positive, HPV positive other than 16-18, and cytology is negative, it is negative for intraepithelial lesion, then follow up in 12 months and proceed for, if that's negative, follow the routine screening. Now, if primary HPV screening is negative, then you follow routine screening 5 to 10 years in the general population and 3 to 5 years in the population living with HIV. So we also have HPV point of care testing, and these are Care HPV test, Quagan, Gene Expert, Advantage, HPV E6 test. All these are simple, affordable, accurate, rapid. The Gene Expert can give result in 35 minutes, and Care HPV can give in 2.5 hours, and learning curve is easily achieved by technicians in these tests. So a little word about self-sampling in women who are hard to reach, or in a woman who may feel embarrassed coming to a doctor, coming to the hospital. So we can do self-sampling, and HPV self-sampling, that women wants to know whether she has HPV infection, and she can use the kit and take the cervicovaginal sample, which is then sent for analysis. And she can collect it with lavage, with a brush, with a swab, or with a vaginal patch. Several studies, they have shown linkage between self-sampling and follow-up, diagnosis and management. So self-sampling maintains privacy, is highly acceptable. It can target the non-attendees. It improves the performance of screening programs. And it has been seen, evidence that participation rates increase from 63% to 78% with self-sampling. It is high concordance with physician collected sample and has high sensitivity for identifying HPV. Then visual inspection with acetic acid. This is being done since long. It's an excellent screening method, still in the low resource settings, and it is done by the inspection of cervix treated with HPV. Just a minute, there is some connection problem. I can go with this also. Just I will.
Yes, ma'am. वैसे you're well heard. Your screen is seen well.
Okay, ma'am. Just a minute, ma'am.
Perfect.
I don't know. So visual via or visual inspection with acetic acid, I think this we can do at a sub-center, any level, primary, secondary and tertiary, when nothing is available, sometimes in emergency also. So this is done by inspection of cervix, and very important is we have to treat the cervix with freshly prepared 3 to 5% acetic acid, and sensitivity is 60 to 90%. It detects more early lesions, but false positive rate is more, which can lead to over treatment. So here we just need a light source, we need a Cusco speculum, cotton tipped swabs, and fresh prepared 3 to 5% acetic acid, which should be applied on the cervix for 1 minute. And this leads to dehydration of cells and coagulation of cellular proteins, and higher concentration of protein in the dysplastic cells reflects the light back to the observer, and the area appears aceto-white. So the lesions on via positive are dense aceto-white, quick to appear and last longer. They have sharp and distinct margin, and they close to and they are in the transformation zone. Now this is a wire test, and here we can see that this is a normal cervix after application of acetic acid, while here we can see there is a very clear demarcated lesion, aceto-white, sharp margins in the transformation zone. And we can see Nabothian cyst in this. These are cervical polyp. And here, this is very important. Sometimes there may be leukoplakia in cervix, and leukoplakia is usually benign. But what it can hamper is that it can obscure the underlying neoplasia. Therefore, all patches of leukoplakia observed, all patches should be observed before application of acetic acid, and they should be biopsies. We should biopsy these leukoplakia lesions before we apply acetic acid. Then second very easy method is visual inspection with Lugol's iodine or Schiller's test, which we had been reading for more than 40 years back also. So you do a Cusco speculum, apply Lugol's iodine, and it will change the color of cervix, and we will read the result. So what is the positive test? There is a well-defined bright yellow iodine non-uptake areas which touch the squamocolumnar junction, or they are close to the os if squamocolumnar junction is not seen. And the areas which are suspicious for cancer, they will stain saffron color. Wherever there is an ulcerative cauliflower growth, that will stain mustard or saffron color, and they always bleed on touch. Now here we can see that what is the principle behind Lugo-Willi test, that squamous epithelium, it has glycogen, and Lugol's iodine, when it is applied, it turns black or mahogany brown. So this is because of presence of abundant glycogen in the squamous epithelium. Whereas the abnormal cells or the abnormal area or precancerous cervical lesions, they lack glycogen and they will not stain mahogany brown or black. They will remain unstained. And the malignant lesion, the frank malignant lesion, as we can see this, they will stain saffron color or mustard yellow. This is Lugol's iodine, very cheap, easily available. So no doctor can say that she came with abnormal uterine bleeding and I took a biopsy, and later on, 6 months later, she is diagnosed with HSIL. So my take home always to all my students, maybe I am admitting a patient to AUB for endometrial sampling, 1 per speculum, And even in there, I apply acetic acid to every patient whosoever I take for endometrial sampling also. So never miss this cervix to rule out the pre-malignant cervical lesions.
Your students are lucky.
No, ma'am, this we have made a routine. In my unit, this is a routine. That patient has come with a cervical problem. Pap smear is normal many a times, ma'am, as the children may make a thick slide and it may not be positive. So in OT, every cervix has to be visualized with colposcope. You may enter that, you may not enter that. So the normal transformation zone does not stain with iodine, while the normal squamous epithelium, it stains dark brown with iodine. Now, there are the different guidelines, different societies give different modalities for screen, triage and treat. Now, screen and treat approach via as primary, when we have done screening with via, then it should be followed by treatment if we find abnormal lesion in screen and treat approach. If we have done HPV detection, then also it can be followed with treatment. Now in screen, triage and treatment approach, cytology when is a primary modality of screening, it should be followed by colposcopy, triage and followed by treatment. When HPV DNA is the primary modality and it is positive for 16 and 18, it is followed by treatment using via triage for those who screen negative for HPV 16 and 18 or who test positive, we do colposcopy and some leap or LETS procedure. Then HPV detection as primary modality followed by via triage and followed by treatment. HPV as primary modality, colposcopy triage followed by treatment. HPV as primary screening followed by cytology and triage followed by colposcopy and treatment. We can follow any of these. All are good. So then these are all various ways how primary screening we are doing by via, by HPV or by pap smear and doing a screen and treat approach. When via is the primary modality, negative, rescreen after 3 years with via test. If via testing is positive, if patient is eligible for ablation, do cryopotry or electric ablation. If she is not eligible for ablation, we can do large loop electro excision of the transformation zone, and then we get a histology, whether it is a precancerous lesion, HCL, or adenocarcinoma in situ, or cancer. Then all cases on via which are suspected of cancer, then we do evaluation, biopsy, and further management. When HPV DNA is primary modality, negative test, rescan after 5 to 10 years with HPV DNA. If this is positive, determine the eligibility for ablative procedure after application of acetic acid or with or without magnification. Then eligible for ablation, do ablation, not eligible, do large loop excision and do the histology. Then suspected cancers, evaluate, biopsy and further management. When pap smear is the primary modality of screening, negative, rescreen after 3 years, well again with cytology. And if the report of cytology is ascus, then immediately triage with HPV test. HPV negative, rescreen in 3 years with cytology. And again it is negative, then rescreen in 3 years with cytology. Now, when you rescreen in 3 years and it again comes ascus, then do colposcopy. Now, if HPV test on triage is positive, then you should treat her, do colposcopy and do further management. You can do again as per the large loop excision or LEEP, whatever is the process, and send for histopathology. Now, then for both the general population as well as in women with HIV, HPV DNA testing is the primary modality, negative 5 to 10 years in general population and 3 to 5 years in HIV population. And when it is 16-18 positive, determine eligibility for ablative procedure, eligible, do ablative procedure, discuss about large loop excision. Then if she is not, you can do anything, ablative procedure or large loop excision, and do histology and go further, whether it's CIN3 or cancer. And if HIV is positive, HPV is positive, then and she is positive for other high-risk HPV also, then we can do wire triage. We can follow steps after wire triage in like we do in wire, and suspected cancer, and evaluate and biopsy and further treatment. So these are the various algorithms which we should follow, and we always keep these in our OT corridor, so that what to go, because you cannot remember so many. The simple test which we are doing for so many years is pap smear testing, a conventional method. It is nothing but a scrape biopsy, but it's very important that it should be taken properly and the report should not come as inadequate sample. So you just take a scrape biopsy with iron spatula and spread them on a slide with a very thin film, and then it should be examined under microscope, and it prevents 70% of potential cancers. It has a low sensitivity to the tune of 50 to 75%, but high specificity to 95 to 97%. So these are very simple in OPD. My protocol is that any woman who visits my OPD, we must do a pap smear. At least she should have 2 pap smear in her lifetime. So whosoever can afford, we charge her. Whosoever cannot afford, we do a concession. Today also we did a screening camp for the women from the slums. So we go to slums, bring those women, and we have given thesis project to the students for pap smear screening in slums of MULLANA. And we have put a project in ICMR for HPV screening in the slums of Haryana, and I hope we get that permission. Because it's little expensive. The HPV screening only we can do with the government funding or with the ICMR or some body can fund it. As such, you cannot afford 1,200 or 1,000 for every patient. So still in majority of places, we are still doing pap smear screening. And we should all know that the method for screening should be accurate. We must scrape the ectocervix with the iron spatula rotating through 360 degree, and at the same time we must take the endocervical washings also with the endocervical brush. The both should be used and the two should be combined on one slide or on the 2 slide, and patient should be very comfortable position when we take the pap smear, and the smear should be as thin as possible, and both sides of spatula should be smeared, and cytobrush sample should be rolled on the slide. Limitations: failure to take a sample from the proper site, loss of cells with sampling device, or if we make a very thick smear, and or there are inflammatory cells or bleeding that can obscure the field, and or if we do not fix it immediately and the smear gets dried, it will not give the proper report. Now for pap smear cytology, earlier we were following NICE system, but now since 2014 we all are following Bhatia. Now there is not much difference, so it should never come inadequate. Our film should be very good. So if it is negative for intraepithelial lesions, then if it is borderline, that coincides with ASCUS, atypical squamous cells of undetermined significance. Then borderline changes in the glandular cell also can be either ASCUS or they can be AGUS, that is atypical glandular cells of undetermined significance. Then CIN1 or low-grade dyskaryosis corresponds to low-grade L-cell. CIN2 and CIN3, they correspond to high-grade squamous intraepithelial lesion. Then squamous cell carcinoma and glandular neoplasia, it corresponds to AGUS, that is neoplastic or adenocarcinoma in situ. Then colposcopy as a screening modality, it started in 1925. It's nothing but a binocular instrument used to examine the lower genital tract epithelium with a white and a green filter under magnification. And it offers us a wide range of magnifications up to 30x. It is, the drawbacks are the large size, cost. Earlier it was not portable, rely on electricity, image storage and transmission and teaching aids. But now we have overcome all these flaws and we have colposcopes with video screens and we have pictures of every case and we can show to every patient and display it on screen, and which is very good modality for teaching all live to all our students. And now these are some of the pictures of colposcopy. It can be, now we can see this abnormal area. This is after application of acetic acid. And this is CIN2 or HCl. And this is CIN3 or HCl. Then now we also have portable colposcopes, and this can be gynocular, pocket, femican, mobile ODT, smart scopes and calescopes. They are less demanding, easy to transport, inexpensive, and they have improved access and performance is comparable to non-portable ones. But we still don't have, madam, you must be having these in Delhi. We still are working with the non-portable one, but we have good screens and they are highly effective. So we can combine multiple contrasts for improving machine learning based classification of cervical cancers. With point of care pocket colposcopes have also come, and these are after pocket colposcopes giving picture after wire, picture after Lugol's application, and picture with the green filters. So these are the newer advances in colposcopies, and over next 5 years, I think they will be available in every second and tertiary care centers and with private practitioners. So primary HPV DNA screening and colposcopy triage is HPV testing may be self-sampled or collected by clinician. If it is positive, we do colposcopy and further management. Then primary HPV screening and cytology triage. HPV screening, if it is positive, you do pap smear testing, and if the pap smear is negative, repeat HPV test after 2 years for the general population and after 1 year in the HIV population. And if it comes positive on the subsequent testing, then you see if it is ASCUS, do colposcopy and further management. So these are polar probe, laser induced fluorescence. They are still investigationals. Then this is a paper by IGMR, and what they did was single visit approach for management of cervical intraepithelial neoplasia by via visual inspection and loop electrosurgical excision procedure. So here what they did a see 450 women visited them. They did via and Willi, both visual inspection with acetic acid and with Lugol's iodine. And if it was found to be positive, Same day colposcopy was done and biopsy was done. And if it was positive, that is read score was more than 3, then leap was done. Then this see and treat approach minimizes loss to follow-up, enables maximum utilization of the scarce medical resources, and in areas where high disease prevalence is there, the risk of over-treatment is correspondingly low. So, what are the recent updates in cervical cancer screening guidelines? Now, ASCCP 2012 were report-based approach, whereas 2019 is risk-based approach. It says that recommendations should be based on risks, not results. Additional reflex triage testing from same lab should be done. If HPV is positive, you should go for genotype and cytology. Minor screening abnormalities, repeat HPV testing or co-testing after 1 year. Expedited treatment is recommended for 25 and above non-pregnant patients with HPV 16 positive or HSIL cytology. Rarely or never screen patients with HPV positive or HSIL cytology should be treated, the treatment should be expedited. So these are the tables of cervical cancer screening recommendations by various societies. We will do of these 3 societies, ACOG, ASCCP and USPSTF. So pap smear, if you're doing with pap test, this is just a revision. Pap smear testing, do it every 3 years as per all the 3 societies, ACOG, ASCCP and USPSTF. If you're doing pap test and HPV co-test, then it should be done every 5 years from 30 to 65 years. And all the 3 say do it every 5 years from 30 to 65 years. And high risk HPV only do every 3 years after the age of 25 years. And every high risk HPV is in HIV positive women. Now, what are the challenges of diagnosis in precancerous lesion or early stage lesions? That patient has minimal symptoms in early stage, and even if she has symptoms, she usually ignores them. Many times patient comes with cervical cancer stage 2A, 2B, and when you go predate to their history, they will say, yes, she had postcoital bleeding 20 years back, but we thought it's just like that. Doctor told us to get HPV testing or pap smear, then we thought it's just like that. So it's even with the educated women. So here comes the role of our counseling. It should be we must spend some time on counseling also, so that they can come forward for screening and early management. Then signs and symptoms may not be specific in early stage. Then minimal screening for cervical cancer, that patient never came forward for the screening. So we can have screen and treat approach only when the primary screening test is positive. Screen, try it and treat approach, the decision to treat is based on a positive primary screening test followed by a positive second test or a triage test with or without histological confirmation. So this is the summary which we have done, that all general population do HPV DNA starting from age of 30 years every 5 to 10 years, whereas in HIV positive start it at 25 years and do it 3 to 5 years. So can we prevent cervical cancer? We can prevent that infection by vaccination, and yes, we can prevent cancer by vaccination. It prevents young women from dying. So let's know about the vaccines just a little. Bivalent Cervarix and quadrivalent Gardasil, this we all know. And Gardasil will work against cervical cancer as well as genital warts vaccine. The first indigenous vaccine for cervical cancer prevention as we have read from Madam's forum also since September, that it has been launched in India and made by India in September 2022, Cervavac. And this quadrivalent vaccine is nearly 1,000 times robust, higher antibodies than the baseline against all targeted HPV types and in all doses and in all age groups. So this is WHO cervical cancer elimination strategy targets for 2030, and we have taken out the page. This has been published in 2021, and we have taken out the page for India from WHO website. Now, if you see that the crude cervical cancer incidence per 1 lakh women in 2020 is 18.7, and cervical cancer deaths in 2019 were 45,000 and now they are 77,000. So cervical cancer mortality to incidence ratio was 0.62. The primary vaccination, we have not even covered 0.5%. Then secondary prevention, which we have talked today, that it is the secondary prevention for cervical cancer lies in the national screening programs of India, and it exists in the 2021 diary. The primary screening test as per 2021 in India still remains visual inspection of acetic acid. VIA still is the primary modality in India. Then target age range of the program is 30 to 65 years. And the program guidelines exist to strengthen the early detection of symptoms at the primary health center level, yes. So VIA is available at every center from sub-center, primary level, secondary level and tertiary level. And we have the clearly defined referral system exists for cervical cancer care in India. So this is what is published in the WHO as per 2021 regarding secondary prevention in India. Now the FOGSI has started SSNPP. This is Swasth Sundar Nari Prevent the Preventable, and this is for WHO call for cervical cancer elimination by 2030. The sad part is that we are just next to China in cervical cancer incidence and cervical cancer mortality, and every one woman is losing her life every 8 minutes due to cervical cancer. So we must take care to go forward with this program and to report every case of pre-cancerous cervical lesions, number of cases where we have done screening and number of malignancies. So this will have an increased awareness on screening methodologies, multifaceted cervical pre-cancer education will be increased, and it is a holistic approach in an educational program, and it is adequate skill-based hand-on training in colposcopy must be taken, and in excision and ablative procedures must be taken by every gynecologist, which is so simple. It is only a matter of learning and doing colposcopy. Every gynecologist of country should be doing a colposcopy, should be doing a excisional loop procedures, lead procedures, and should be doing ablative procedures. My teacher, Dr. Ashiyar Serene, I did my post-graduation 40 years back, and my thesis at that time was cryocautery in benign lesions of cervix. So she purchased a cautery for the college, and every day we used to do 18 to 20 cryocautery. I had to do 500 cases. So I think 40 years later, there should not be any gynecologist not doing ablative or excisional procedures or colposcopy. So take home message today is that HPV primary test is recommended for secondary prevention. Co-testing is the preferred method of screening beyond 30 years. It increases screening interval. Visual inspection and after application of acetic acid via, it appears promising as a population-based strategy in low resource settings. No screening is required before 21 years of age, and preferably screening should be started at 25 years of age. HPV primary testing is recommended method for secondary prevention. HPV biomarker assays are more meaningful markers, and above all, hard to reach women, they must be reached. Only then we can make Bharat cervical cancer MUKT. So the women who are labor class, this is the slums, this is the population which direly needs cervical cancer screening. Jai Hind.